Good morning, everyone. We're going to go ahead and get started. It's 6:30. I want to start by saying the CME number has changed. So when you text for your CME credits, please use this number 16734 instead of the one for 2025 in order to get credit for this meeting. Last April, Dr. Chris Childers gave a presentation at Grand Rounds about RVUs and the history of the RVU system. And after Grand Rounds, we usually have an email go out with evaluations, and there's a section on the evaluations where participants can request other meetings or topics for meetings. And usually it goes empty, but after Dr. Childers' meeting and presentation in April, there were a lot of requests for more information on RVUs, how we get paid, billing, reimbursement. Today we've invited two speakers to come for UW Medicine to address some of the remaining questions after that talk. We have Erica Floyd, Executive Director of Faculty Practice Plan Practices at UW Medicine, as well as Matt Lund, Chief Contracting Officer of Contracting and Payer Relations. And they've graciously agreed to come at this early hour to come and answer questions and share some more about these topics that have been requested by participants. So if we could please welcome Erica and Matt, come on down.
So good morning. I'm going to let Matt do a lot of the heavy lifting. I have to say, I feel kind of humbled, though, to be here to talk about RVUs, knowing we have like an expert in the house. I think there's some work in progress to get you to try to join the UWP Finance and Audit Committee even. But this is a really timely topic too. We're in the midst at UWP of working through the 2026 changes to RVUs. And so going through the analysis on that. But Matt has a great perspective on how contracting works within the system and how professional billing fits within that, because they do contracting for all of that. So I really wanted to lean on the expert here. So I'll let him introduce himself and kick it off.
So thank you for having us. My name is Matt Lund. I'm Chief Contracting Officer at UW Medicine. And so what we'll do today is go through just how contracting works at UW Medicine so you understand the basics of that. We'll get into this whole idea of how it is we get paid for the service. Specifically, when we do the medical services, do the coding, send off a bill, what comes back? What amount of dollars come back? What relationship? Oh, sorry, there we go. Oh, great. Hey, everybody on Zoom. Didn't even know. So as I was saying, really want to kind of focus on that whole idea of we bill for services and then money comes back. Why is it that money comes back? Why that amount of money? And that really starts to get into this whole idea of what's an RVU, what's a conversion factor, how does that play with our contracts, give you a good taste of how all this works. And of course, always time for questions. So, all right. So I'm gonna. All right. So. Which one we got here? Oh, there we go. Got it. No worries. Okay. So some of you may have heard a version of this talk before, but what I've done is I've set this up. We set this up to be a real focus on professional billing to help with the billing providers understand a little bit more. So we'll go over these basics today, how managed care contracting UW Medicine works, this whole idea of how is it that how do we get paid? And interesting thing is, that there was an administrator here at UWMC years ago. We were talking about contracts and all this kind of stuff. And it's someone who, at the time I thought, well, of course this person knows how we get paid or something like that. He said, well, how do we get paid? And it made me realize that, for me, this is every day, but for a lot of people, it is sort of this esoteric concept. So it's good. And I think it's important for providers to understand how this works, at the very least, so you can empathize with your patients, but also understand how the business works. And frankly, all of us as consumers, it's good to know how this stuff works too, because we'll all get healthcare at some point in time. We'll go through fee-for-service reimbursement systems and methodologies with a focus on professional. Talk a lot about how Medicare and how Medicare does things really impacts Medicare is doing it. Probably everybody, all the other payers are going to be doing it soon. If they're not already. Takeaways and Q&A. If any questions come up, just stick your hand up. Very quickly, managed care contracting, UW Medicine. So that's my department. There are 16 of us. We do the contracting, that is contracts with insurance companies for the entire system, hospitals, the professionals, and also Airlift Northwest. Until recently, we also did the contract for Valley Medical Center and Valley Medical Group. That's commercial managed government payers, kind of any sort of managed government payer you could think of, Medicare, Medicaid, VA, CHAMP, VA, TRICARE, et cetera, labor and industries. We focus on the total annual take for. So we're really trying to manage our payers as a portfolio and each year preserve and maintain that profitable net revenue and continue to make our ends meet as best as we can from year to year. About a little over $3 billion a year in annual reimbursement for the system. That's never enough. And so it's a lot of money, but it's never, we're always trying to sort of fill that gap. So here's just some for background. Very basic look at the payer mix of UW Medicine. These are gross charges. This is for calendar year 24. As you can see, about 43% of our commercial charges for the system were with commercial payers. That's the Regence, Premera, Aetna, that kind of thing. About 33% were Medicare, 20% Medicaid, and so on. That's the gross charge. So that's the bill that we send out. That's the retail price. And then this to look at what it is, what we actually get paid. So if you look here, the commercial piece of the pie gets bigger and the government pieces of the pie get smaller. The most basic takeaway from this you should take is that commercial insurance pays more than government payers, and really quite a bit more. And there's an example that will illustrate that in a bit. So that's the system. So if you go back, we send out bills of 10.5 billion. We in return get about 3.36 billion. So that's a big discount, big haircut on the services. Okay. UW physicians, this is just the doctors, just the professional billers, doctors, ARNPs, and so on. Similar pie chart. And about 1.8 billion in charges go out. 642 million come back, give or take. And so you can see the same thing here too. So see the difference in the commercial piece of the pie there. We see about a third of our patients, the bills are for Medicare, but what we get back from Medicare is a lot less. Commercial makes up a lot more. And so no patient is more important than the other, but some pay more than others. So it's just an important note. Getting into the question of how it is we actually get paid. So we talk, about how we send out bills, $10 billion, we get about $3 billion back as a system. Why is that? The concept really starts with Medicare. How does Medicare reimburse things? It's a little bit of an exaggeration, but really is a good rule of thumb. It's good to think that really the charge we send out bears no relationship to the amount of money we get back. It's like saying, I'll charge you, $5 to mow your lawn and you give me an apple. And I'm like, great, this is, you paid me. This is how it works, so it doesn't really make a lot of sense. So what we'll focus on today mostly is this one, RPRPS. That's the way the professionals are paid for their billing. We'll also talk about DRG and APC as billing concepts and reimbursement concepts as well. Those are for the hospital facility component of reimbursement, and that's important to know too. But the term RVU comes from the RVRBS. We'll talk about that in a second. So yeah, we'll focus on RVU. So RBRBS, just show of hands, anybody heard that term before? heard it, right? Okay. So this is a CMS concept, Medicare concept, resource-based relative value scale. This is CMS's attempt to standardize a way to look at the services that every professional, every doctor across the country provides, and say, yes, everybody's different. The services are all performed, similarly, but also differently, uniquely. But we're going to look at them the same way to be as fair as possible when reimbursement goes out. Um, one of the big things to think about here is that whatever it is we charge, we get a lump sum payment back from CMS. Again, the amount we charge, and I'll discuss the caveats here in a moment, doesn't bear a whole lot of relationship to what it is we actually. So what CMS does is they have this formula that says what it is we pay for the service, no matter what it is our bills say. And so I'll get into some of these concepts here. I think the biggest thing to remember, if you're going to have any real takeaway here about how it is the system works, is this equation at the bottom. And I'm going to have this at the bottom of pretty much every slide from here on out, so you remember it. RVU times conversion factor equals payment. That's how it is that you're going to get paid. And so we'll learn about what all those components mean. Okay, so RVU. So we talked about RVU times conversion factor equals payment. The RVU, I hear a lot of, especially the doctors say, well, work RVUs. I got to get my work RVUs. So work RVU, that's a piece of the CMS or RVU concept. So really there are three pieces of the RVU. There's the work RVU. That is how CMS has decided what each service anybody's ever going to provide is worth based upon the time and intensity associated with furnishing the service. Again, this is Medicare sort of saying, okay, this particular service you're doing should take this much time, this much intensity, background training, etc. So we're going to value it thusly. Another component is practice expense. This is how CMS conceptualized the cost of your workspace and the materials and everything else that it's going to take for your medical clinic to be able to do this service. Practice expense. And lastly, when I first started learning about this is the one that I thought was the most interesting, was the malpractice insurance expense. So CMS actually includes in every single RVU, every single service you provide, a little bit of extra money there, extra in quotes, for the malpractice, for your liability that's going in there. So there's always going to be a little bit of a zhuzhing up of the RVU in order to sort of at least sort of pay attention to the idea that there's a risk to the service that you're doing. CMS comes out with a final rule every year in the fall. And that is where all of these new updates to RVUs and the conversion factors and anything else having to do with the way CMS is making payments comes out. If you've ever looked at it, it's hundreds of pages long. I think that this is probably the best use for AI these days is to sort of ask it to summarize it for you. A little bit of a joke, but you'll find, a day or so after the rules come out, all of the different consulting groups, law firms, et cetera, will have to say, okay, here's a summary, here's the highlights of what's going on in the final rule. And then you'll see, okay, CMS this year is going to prioritize primary care over specialty. We're going to prioritize behavioral health over something else. Sort of adjusting how it is. The payments are going to be made based upon the policy that CMS wants to see in healthcare. So what becomes important to me or to my staff, our analysts, are, well, what's the RVU year for a particular contract? Because that really says how the math is going to work. The RVUs change every year. The conversion factors change every year. Stay pretty similar, but the way that our contract pays is going to be based upon how the RVU year that's reflected in the contract. It's kind of less of a thing now, but there have been times in the past where we've seen a particular RVU year or DRG version or something like that that's better for us. And so we sort of try to say, well, it's 2026, but maybe let's see, what if, hey, payer, what if we go with the 2023 RVUs instead, that kind of a thing, see if we can make it work that way for commercial paying. I'll get into that in a second. Each So each RVU component is adjusted to account for the cost of providing care in the applicable geographic. So we'll talk about that. Do you want to that, Gypsy?
I was, well, not necessarily the gypsies, but I did just want to say that I'm going to provide a little clarity maybe over how UWP and RVUs are, what the timing is for us. I mentioned that the 2026 rules came out, or final valuations came out in November, December time period. And we do a extensive analysis for the whole of the UWP book of business and then each department as well, and determine that the impact of those valuation changes. One thing that is kind of important to note is we don't actually update the RVU values for 2020 for the 2026 new valuations until July, which marks the start of our fiscal year. So from January through June, we'll still be counting or crediting work to departments for PSA, for physicians, for, kind of productivity, incentives, all of that. We'll still be using the 2025 values while we continue to analyze and plan for what the impact is of the 2026 changes. What I will say also in terms of Matt saying, cherry picking a good year, 2026 is not a good year to pick for us. I can tell you that, having done some of the preliminary analysis. There's CMS in 2026 has done two kind of they've added two elements to the valuations in 2026 that I'll get into a little bit later. But I think, again, it's important to recognize that from a, kind of how we credit and account for work here has a little bit of a timing difference compared to what CMS does. That said, CMS starts paying us for Medicare rates based on what they put out in 2026, regardless of when we change our RVU valuation. So I think that's an important piece, though. Sorry, Matt, didn't mean that.
No worries at all. And I think, so Erica brings up an important point too, and that is that I think we look at RVUs in a couple different ways in our system. First is the way CMS is actually paying money, or the payer is paying money into the system. And then there's how we use RVUs internally to then take that money and figure out how it's distributed to the various professionals. So this is RVU. So it's three components, okay? The work RVU, practice expense, malpractice expense. So, and then as I say here, RVU components are adjusted based upon geography. So in Seattle, we have an adjustment that's made in the RVUs. One thing that's important to understand is that RVUs are based upon the service. Okay, so CMS sets these RVUs for the service. So the base RVUs are the same for every single doctor in the US, with some geographic adjustments. Some of the geographic adjustments are helpful, some of them not so much. Just for instance, these were the geographic adjustments for Seattle last year. So the work RVU was multiplied by 1.05, practice expense by 1.227, and malpractice expense was 0.0851. It makes no sense. Yeah, totally. And I think a lot of it is just results based. Like, well, we need this to kind of be balanced. We'll give them a little here, we'll take it away there. Look, it's all budget neutral. Yeah, exactly. So you'll see here in a second the conversion factor was down last year before. I'm like, oh, because the cost of care went down apparently. So I don't know. But it all sort of is just this, we're subject to what CMS does. Yes, we sort of have to figure out how we can with it. And so, but those of us, those of you practicing in Seattle, you all not only have the same RVUs for the services you're going to be providing, but you also have strike that same RVUs as the doctors across the country. All the doctors in Seattle have the same GIPS adjustments and geographic adjustment. So as I said before, RVU times conversion factor equals payment. So now we've got the RVU piece of this. We've covered that RVU with three components. Adjusted for geography. Okay, so we've got RVU, then you multiply that times the conversion factor. What's the conversion factor? Conversion factor is a dollar amount. Okay, so where the RVU is a way to sort of weight the service. Okay, I'm not a physician, so I feel silly saying this, but is the service easier, or is it harder? I think is kind of how they look at it. So the more difficult, more time intensive, so on. Services are going to have a higher RVU, and the lesser, sort of more simple, forgive me, services are going to have a lower value. And then you multiply that times the dollar amount. So right now in 2026, the conversion factor is $30.40. So if the RVU comes out to two, then you get $66.80. Yes, exactly. Right. Yeah. That's math that a non-science person does. So my example for medical is always also if you break your leg, which is funny because I'm like, yeah, I'm sure there's much more complicated things than that, but most I can come up with. This is the conversion factor. No matter what area of medicine you practice, every doctor in this room has the same. Okay. So you will have your conversion factor, you multiply that times the RVUs for the service provided, that's how much you get. Okay, so that though.
A little bit about what's happening in 2026. So what you'll see is between 2024 and 2025, the conversion factor went down. And that's what Matt and I were referring to, a result primarily of budget neutrality. Essentially, there's a set pot of money that will be used for all of this, right? And so it really, the constantly every year, it's this kind of shifting of the deck chairs or moving of the deck chairs around a lot, right? Because they're saying there's not going to be new money. So that's why the conversion factor went down in 2025. You'll see the conversion factor went up in 2026, which on its face looks like great news. But if, again, within the lens of budget neutrality and all of that, there's not because there's I think we all know this, a vast amount of new money to fund for healthcare and Medicare. This is actually being done at the expense, if you will, of some adjustments that are actually impacting work RVUs and TRVUs, particularly related to services performed in hospital settings. So there is a lot of impact that we're anticipating in using 2026 RVU values for that. So again, on the face of this is would seem like good news, but unfortunately, it's within kind of the overall context of some other negatives that are what I would consider to be drags on healthcare reimbursement.
CMS is trying to figure out how to split up the pie of money we have. They have this fairly. Yeah, right. Yes, it's we, yes. But there's this limited pie of money and they're trying to figure out how to split it up. And we sort of have to deal with what it is that they come up with. Okay, so we've discussed the conversion factor. That's a dollar amount. And the RVU. So you multiply those two together and you get the payment. So this is on the CMS website. But this is sort of a more formal flow chart of how it works. But if you look, this just has the equation. You want to see it. It's interesting. You can dig way into how it is that these are actually all put together. It's actually, some people might think it's fast. I think it's interesting to see how all this comes together, how the sausage is made. Here's an example of how all this works in real life. So we have a CPT 99213 established patient level 3, probably do these visits. So this goes through. You've got the CMS assigned work RVU value, the practice expense value, the malpractice RVU value, okay? Those three components that make up the RVU. Then you adjust them for geography. You've got the gypsy adjusted RVUs here. Do the multiplication on those three, add them together, come up with this number right here. That's the RVU value. You multiply that times the conversion factor, $32.35 each last year's. And for that level 3 established patient, you get $100.06. Don't spend it all in one place. That's what Medicare pays for that. Now, I have put mostly to remind myself down here in very small writing there that the bill that we send out for that is actually $302, and we get $100 back. Yes. Mhm.
Right, so for the faculty, when we get reports on our RVU billing, is that just the work RVU, not the total RVU? So if I bill a 99213, I'm going to get credited with a RVU of 1.6, not 3.09. Just clarifying that.
Yeah, important for us to understand the difference between WRVU and TRVU. Because you're locally talking about TR.
Correct. It's how we get paid in the system. So Medicare would send $100 for that service, and then it comes into the system, gets divvied up. So $60 or something like that is usable for that work RVU. So something to that effect. Noteworthy. Medicare reimbursement rarely covers the cost of the service. Almost never does. Medicaid definitely does. Think back to the pie charts that I showed you, about 2/3 of our payer mix are these government payers. It's all the same, but labor industries, PA, TRICARE, whatever. We have no aversion to seeing those patients. Most of the time, I think our doctors don't even know who the insurance coverage is, but we lose money. And so, yes.
Yeah, just because you're mentioning the reimbursement, there's a question in the chat here. So in relation to the reimbursement pie, this is from Dr. Foy. Per dollar billed, what is the payment percent for commercial Medicare and Medicaid?
Typically, we're looking at about for commercial. For commercial, we're typically looking at about 3 times. That's typically the goal. And that's not something that we necessarily are going to sort of shout from the rooftops, but it's what it takes to be able to sort of keep things going, is to sort of continue to press the payments on that. So, as I mentioned before, this is a Medicare concept, this whole idea of multiplying RVUs times the conversion factor, but it's also essentially the same system that you're going to see in all the other payers too, Medicare, Medicaid, commercial. So for, like Aetna, for example, their RVUs are basically the same. They definitely, call the tie. The tie always goes to Aetna, when it's, when they want to adjust things, make it a little easier for themselves on payments. This is basically how it works with everything. For the most part, we're trying to get to that reimbursement close to about 300% of Medicare or higher. And so that's good.
I'll ask one more question for you, Matt. So do we have any control over what gets passed on to the patient? So if we bill 3 times the bill, we get paid 1/3 of it. Is it on the insurance company to determine how much the patient pays? Because that is highly variable, I think, as well.
It is. It comes down to the way the patient's benefit is set up. So that's always going to be up to the insurance. For the most part, patients are going to pay the least amount of their cost share. Well, it really depends on 2 things. First, if they're coming to us in network, they're always going to pay less, sometimes nothing. And depending on the richness of their benefit, if it's the terms bronze, silver, gold, platinum plans, for example, platinum plans, typically patients have paid a lot of money up front in their premiums, and they're going to have very little cost share. The lower bronze and so on are going to pay.
But we don't control that. We don't negotiate that on behalf of the patients, right? We basically only control we only negotiate what we get paid.
That's correct. And so, that you make a great point, because let's say this is a commercial reimbursement for this CPT, about $300. The payer, the allowed amount is $300. The payer is going to pay us like $250, let's say, and the patient is responsible for paying the rest. The insurance company doesn't front that money for the patient. And so it's up to us to be able to actually collect that money from the patient. So frequently we end up actually getting less in reimbursement because patients can't pay, don't want to pay. We somehow don't collect it or whatever reason. That happens a lot too. There's a lot of uncollected money out there that the patients owe us because for whatever reason.
I also just want to highlight the fact that the charge is the 300 and 250 for a patient who comes in who's uninsured and does not qualify for assistance. Say, we do have a discount that's applied. It's a 30/10, so it's prompt pay and at the time of service. And so essentially, they get a 30% discount and then a 10%, which ends up being, again, my 6 o'clock or 7 o'clock now in the morning math, 63%. So they get charged 63% of that $300. You'll notice that a uninsured individual that doesn't qualify for any assistance, financial assistance from the system, actually pays more than Medicare, right? So they pay $180 compared to Medicare at $100. So again, I think the economics of healthcare can be, the more you learn, the more troubling I think sometimes it can feel. So.
How it's important for us as consumers to understand this also. Oh, sure. The practicality of this for all of us is just that this is the system we live in too, and it's confusing even to us. I mean, I had a family member with some health problems about a year ago, and then sort of being in it like, oh my God, I'm the one who's supposed to know the most about this, and it's confusing. So it's just important for us, just at least for empathy of all this. Can anybody think of a reason why it is we might charge so much and only get, and knowing we're going to get paid so little?
So one reason is that if we bill less than what the payer is contracted to pay us, we get the lesser. So if we had billed $90 for this visit and Medicare, if the Medicare allowable is $100, Medicare is going to say, we're just going to pay you $90. Okay. We're always chasing the highest negotiated amount with our bill charge. So if, let's say, we've negotiated with a commercial payer a way that's going to pay for this service at $350. If we've only charged $302.50, we're going to get $302.50. And so there is an effort always going on with our analysts to try to make sure that we're noticing where we've undercharged for certain services. And so that's always sort of moving up as well. They call that the lesser of. You'll pay the less. They pay us the lesser of. And so for me, I mean, I am interested in keeping those charges up because we go through months and months and months of negotiations. If the charges are too low, I'm wasting time getting the increases. But we need to be able to get them. Yes.
Oh, we have another question from the chat. You mentioned that Medicaid might not cover our costs. However, I was under the impression that Washington Medicaid reimburses at commercial rates. Could you elaborate on this?
Sure. So that's true to a certain extent. In Washington, we have what we call a directed payment program, but this applies to hospitals. And so there is a well, let me back up. There are two programs. There are directed payments from inpatient and outpatient. Then there is a SNAP. What do we call it? Anyway, it's PAP, physician assistance payment, where through government transfers of dollars, we're paid a little bit extra at the end of the year to try to get the reimbursement amounts closer to commercial. It says commercial, but it's never actually up to commercial.
One thing I would just point out related to those supplemental payments too. So when a payment comes in for a specific service from CMS or from a commercial insurer or a patient makes a payment, it essentially is posted to their specific account, attributed to that service very specifically in our system, and we can analyze it that way. If we get these kind of lump sum direct payments from, MCOs, if it's PAP or directly from CMS, if it's PSSP, those aren't actually reflected on the specific service in our system, right? So they're just considered a lump sum payment. So it is a different way in which we do our internal commerce related to that. And we don't look at it in terms of that, but it's a huge element of funding for the hospitals. It's also a significant amount of funding at UWP. I think we got about $100 million last year in the direct payment program. So and 650 million or so of fee for service, actually collections from commercial and all the rest. So it's not insignificant at all. And the changes legislatively that are happening related to that will have a big impact. But it continues to be an important source for now.
And for now being the operative statement there, because I think we all expect those programs to come. The latest that I've seen is that there might continue to be a directed payment that brings Medicaid up to Medicare, not all the way up. It never reaches commercial, the average commercial, but it does get closer, at least to and above Medicare. But it's going to be hundreds of millions of dollars per year that are sort of lost. That we'll have to figure out how to do it, right? So someone all of a sudden cut your paycheck by some huge percent. What are you going to do? You know, you got to figure out how to live more frugally. I think we'll need to figure that out too. So that's how that works. Or start driving Ubers. Exactly. You can all get a nice side hustle. Sure, that'll be great. Your parents will be so proud. So this is how this works. Okay. As I said before, so I'll go through this in a second as well. But as I said before, if you understand how Medicare pays these things, you'll have a very good understanding how all payers pay. This with very little variance with that. Very quickly, I'll go through how hospitals are paid. Very similar concept to the way that the professionals are paid. It's a lump sum payment with a very similar equation. Instead of RVU times conversion factor, it's a base times a weight, but a similar concept. Instead of calling it a dollar number, a conversion factor, they call it a base. CMS assigns a hospital specific dollar amount base. Every hospital in America has a specifically assigned Medicare base dollar amount. UWMC has one, Harborview has one, but different. Valley has one, Valley different. Again, intended to sort of take a look at that hospital and say, okay, based upon where it's located, the patient profile, the amount of uncompensated care, they put this together, try to say, okay, this is a fair dollar amount. Weight applies to the diagnosis of the case. Okay, is this going to be a brain surgery? Is it going to be a broken leg, fixing something like that? It's something inpatient. That's how payments are made in patient hospital. Again, it's a lump sum. And so when you have your patients inpatient in the hospital and they're there day after day after day, and we're generating these bills, doesn't matter a whole lot. Okay. Actually, let me take that back. It matters a lot, but it doesn't necessarily have relation to what it is that we're actually paid in the case. DRG is going to be a lump sum payment. Okay, they're going to say this surgery is worth X amount of dollars, and we'll get paid that amount. The only difference that's made there with the billing and the time that a patient's in the hospital is that there are times when the cost can be so high it hits what they call a cost outlier, and CMS will start to pay us a little bit more as a risk share. But the costs of the care typically will overwhelm what we're paid.
How does the case mix index factor into this, or does it not?
The case mix index is sort of, I'm not sure exactly how that factors into the DRG base. I think that's a little bit more of sort of how we look at things. It's our case mix index.
Oh, how it's different hospital billing. So the base for each hospital for the Northwest campus and the Moffett one.
Correct. Because it's one hospital, it's going to be the same. It's a great question. So, and I've been around long enough to where I still think of them as two hospitals, even though they're not. It's one hospital that happens to be in two different places, but same tax ID number, it's the same based on. So, yeah. Any questions on this? Okay. Next, so this is inpatient health. Someone comes in, they get a service, they stay here for more than 2 days. That way. And that's how the inpatient prospective payment system, that's how this works. It's another CMS concept. Every year, CMS final rule, they put all of the DRG weights, conversion factors, and base hospitals, and this is how it's paid. Biggest thing to remember though is we get a lump sum payment for that service. So the efficiency of the resources we're using is this is piecework. When I was a kid, I was thinking of myself as a fairly industrious kid. I would mow lawns in the summer and I would shovel people's driveways of snow in the winter. Okay. And I would charge everybody about $10. Big lawns, $10. Yeah, I know. Big lawns, $10. Small lawns, $10. Big driveways, $10. Small driveways, $10. It had to be important for me to get the work done as quickly and as efficiently as possible and not have to go back and hit some areas of lawn that I missed. Okay. I'm not comparing, well, I guess I am comparing, but I'm not trying to do so in a disrespectful way, the service that you do to mowing lawns or shoveling snow, but you think about it as piecework, the efficiency of the resources that we use. Okay. That doesn't mean that we scrimp on care for patients. It just means an awareness of the resources important because probably not going to get paid where resources are used sort of inefficiently. Next, APCs. So we talked about hospital inpatient services. This is hospital outpatient services, where we do a service at the hospital and, someone discharges the same day or, less than 2 midnights. You'll get this service. It's extremely similar to the others. Conversion factor. We're back to calling it a conversion factor again. I'm not sure why CMS decided to call the dollar amount with inpatient services a base and outpatient services a conversion factor, but it's essentially the same concept, the dollar amount. Every hospital for outpatient services has a CMS specific dollar amount assigned to that hospital, comes out in the final rule every year as to exactly what it is. And there is a weight assigned for the APC, ambulatory payment classification, outpatient service that you're providing. Colonoscopy has an APC. You are colonoscopies in the hospital. So that's an outpatient service. There, CMS has a weight associated with colonoscopy, probably different levels of colonoscopy. I'm not exactly sure how that works. And they multiply that times the dollar figure, and you get a lump sum payment for that. Any questions on how all this works? Let's raise any questions about talking. And there's how the outpatient prospective payment system works right there. Outpatient, CMS concept. Again, you know how this works, understand how, have a basic understanding of how it works with CMS. You'll know how it works with virtually every payer. I say virtually because there are still some old school contracts out there that just pay us a percent of what we get. Those are great. I never want to let their time is coming. That's when the charge isn't getting 80% of the charge. It's great. But those dog days are over. Let's see here. Commercial reimbursement. Summarize it again. You understand how Medicare works. You're going to understand for the most part how commercial works. Typically what we're doing with commercial is we're negotiating on a lot of different aspects of the contract. But at the end of the day, we don't do a whole lot with the weights or RVUs for the service. We are focused on the conversion. The higher we can jack up that conversion factor dollar amount, the better we're going to do. So as I said, we're shooting for about 300% of Medicare in our commercial contracts. So if we can get that up, then that's really where that comes in. We still have some percentage charge contracts, W Medicine, as I said, and nearly every contract we have now has some sort of a value base. Medicaid is similar in Washington. They also use the RVRVS, they use DRGs. They don't use APC, but they use something very similar called the APG. All of the basics of payment same for basically every payment. Sometimes it comes down to the brand of software. So the state of Washington uses 3M software. They don't call their DRGs a Medicare DRG, they call it APR DRG. They don't call their APCs APC, they call it. But it's basically conversion factor times the weight times the RVU equals your payment. So here's the takeaways. that I'm hoping that you'll take from here. Again, you understand how Medicare works. You'll understand how all of the reimbursement works. We get paid in a lump sum for this. It's not a matter of necessarily the more work we do, the more we get paid. At a certain point in time, there's a diminishing return there. And so getting, remember that we're getting paid piecework for the services that we do. All these weights are set by CMS. Very difficult to negotiate a change to those weights. We do some unique services here at UW Medicine. For those, we do have some uniquely negotiated weights for services. For the most part, it's going to be the same all across the country. We focus our reimbursement strategy on the total each year. So that means we will pay attention to some service lines specifically. But for the most part, we're trying to grow that big bolus of cash, bring in as much as we can, and divide it into. And lastly, I have here efficiency and utilization or cost management is the key to success in our current business environment. Our cost is king. Cost is king was something that was said to me by Mara a few years ago. I never forgot it, and it's true. I didn't like it when I heard it, but it's right. They don't want to pay us. And you need to understand that the resources that we use cost money, and we're not necessarily going to get enough money to all this companies.
Just a quick question. Could you go back to the slide right before this? And you're mentioning how most Medicaid, the one before this, most Medicaid beneficiaries have Medicaid managed care. And can you talk about what the landscape of that looks like in Washington State, and does it matter which insurer manages the Medicaid for a given Medicaid patient?
Great question. So when Medicaid expanded in Washington, it changed from a reimbursement for Medicaid system that was run by the state, specifically the healthcare authority at the time, the DSHS was the payer. So they had a full apparatus there to be able to receive claims and process them, pay them. When Medicaid expanded and the number of covered lives in Washington expanded, they farmed it out, that practice out to 5 different MCOs with managed care organizations in the state. So you have Community Health Plan, Coordinated Care, AmeriGroup, now known as WellPoint, United Healthcare, and Molina. And they essentially stand in the shoes of the healthcare authority. They receive the claims, they pay the claims. They're paid by the healthcare authority a premium each month for each patient that they manage the money for. I think that when it's a good question. Essentially, if I'm hearing you correctly, is one of the MCOs better for the patients than the others? The truth is, I really don't know, and it's going to kind of depend on the patient. Each of these MCOs, sort of like Medicare, where you'll see the commercials, hey, we're also going to give you glasses or something like that. They have these extra benefits. The different MCOs will offer different benefits. And so it's up to the patients to sort of figure out which one's going to be the best for them. I'm not sure. I mean, just sort of judging by, I think, how I just know the people in my life on all kinds of insurance. I'm not sure. It kind of depends on how good of a consumer you are and how does he pick it. I think that in terms of which one's best, I really couldn't say. There are definitely some that we find easier to deal with than others. From a administrative standpoint, they're all pretty difficult to deal with. But it's an excellent question. I think probably the best input you can give to a patient is for the patient to try to do a little bit of homework, get on the web. The nice thing about procuring Medicare or Medicaid coverage in Washington is it's done through the health insurance exchange. So there is a chance that they can go on there and kind of compare everything side by side, looking at the different variables and the like terms.
Thanks so much for that talk. I thought that was one of the more clear explanations I've ever seen of such a complicated topic. I think the title of the talk was How We Get Paid. And I think you've done a really good job of explaining how the institution gets paid. And I was just wondering if you guys can dive into a little bit about how we get paid as surgeons, especially for the trainees. I didn't see anything about an associate professor getting paid more for doing a surgery than an assistant professor in that fee schedule. So how does that all work?
So in the fee schedule, it would not be reflected, right? Essentially, it's agnostic, if you will, to the level of individual. Obviously, within the university system, the compensation level of our practitioners will vary significantly based on levels. I do know incentive plans sometimes can be meant to level set some of that, and that that's work that we do at UWP with each of the clinical departments based on the goals and objectives of the department in coordination with the system and all of that. I think one thing that's really, I guess there's another question, but I did want to just touch on kind of the critical nature of complete, accurate documentation on the part of our practitioners to reflect the complexity of care that's given to our patients. Because the more that's documented in regards to that, the more appropriate billing and RVU, the more appropriate the billing can be, the correct CPT codes are selected, all of that, right? The complexity is reflected in that, and then the RVUs will increase for that as well. So it's, kind of the piece that this is about how we get paid, but there's a huge component, right, on, what's documented, how that's translated into a CPT code, and the charge goes out the door, right, based on that. And then there's a whole body of work that is done at UWP as well, related to after the claim goes out the door and a denial because a managed care plan, we didn't get pre-auth or something like that. And so being able to work denials and make sure that we're getting as much payment as possible, in terms of where the reduction of our write-offs, I guess I would say, are minimized. So there's a huge amount of work that goes on in that area. To give you an idea of perspective, there's about 130 professional coders, 90 or so boots on the ground coders, then supported by a team of additional 40 or so people that do everything from education and QA to managing some of the that large team. So there's about 130 in coding, and then there's 100 or so people in patient financial services, which that has to do with dealing with the government payers and the commercial payers on working, submitting claims, posting payments, working denials, essentially working to ensure that the organization it gets as much money as possible from the claims that are. So I know the work that's done with practitioners tends to rely on kind of coders and all of that, but there is a whole body of work that happens kind of after the claim goes out and as well. So
Here's a try. Didn't notice anything odd in our coding. That's a great excuse for them to not pay us for the service.
Think about it. Patient comes in, they want to see you, they do. You perform your services, you maybe save their life or save a limb or something, and they're really happy and they're telling all their friends about what a great job you did, but the insurance company's like, yeah, but you didn't document this correctly, so we're not going to pay you. Okay. So that happens a lot. And so that's really important. Secondly, the accuracy in your coding not only affects professional reimbursement, also affects facility reimbursement. The different levels within APCs, for example, are based upon the complexity of the case. So if a case isn't coded to the right specificity, we probably won't get paid as much as we should. Okay, so you've just worked your tail off, used a bunch of resources and materials and equipment and that kind of thing, but we're getting paid as if you did less work. That's what happens there. Lastly, ever want to be a system that can go out and capture business, like go direct to Microsoft, for example? We have to be able to code correctly, because if we can't do that, then we will not be able to charge the correct premiums for those services. So I hear a lot of chatter from saying, why aren't we going after this big employer groups and that kind of thing? We're getting there, but we have to make sure that our coding and documentation is correct, or else we'll really we'll not be able to survive going. So
Matt and Erica, thank you for being here and for this great presentation. I want to make a comment recognition and then a question. So one thing that I think got glossed over, it was in between the lines, is actually the work RVUs for most surgical services have taken a haircut this year because Medicare has assessed that we are more efficient than we used to be, and we are better at performing care with less work. One of our faculty, Dr. Childers, has actually first author on a paper that looked at that systematically and demonstrated the opposite. That because of the increased age, complexity of the patients that we care for, that the work is more. Yet, in spite of data, Medicare has made the assessment that they don't need to give surgeons as much credit for the work that we're doing. So I just wanted to thank Chris for that work that he's done. My question is related to, go to the next slide, because you said it at the beginning and you said it at the end, that contracting is based upon the total amount of money that we get. Just the next, yeah, that's the next to the bottom bullet point. What percent of our money is facilities versus professional? And what weight do the physicians and departments have in participating in contracting? How is that related to the weight between the total facilities billing versus professional billing?
So earlier it's a good question. So earlier in the slides I showed, the facilities take in about 3.3 billion per year, give or take. UWP took in about 650 million. Okay. So there's obviously more money that comes in from the facilities. I will tell you that there is no favoritism done between the two. Both have to be able to keep the doors open. And so we negotiate as a pack. In other words, I'm not going to a payer and negotiating UWP and then coming back in a few months and negotiating UWOC. One of the nice things about the coming together of UW Medicine is we're able to negotiate as a block. And so we go into the payers and we say, this is how much we need. And so we look at the costs that UWP needs to be able to handle in the coming year, what we think is the correct adjustment based upon things like inflation, drug costs, supply costs, tariffs, labor, and so on, and see how high we can push that up. Very little. I'll be frank, very little. The truth is, no, because, and I'll challenge this. I'm not sure what value you could add. And I'm not saying that to be disrespectful. This concept doesn't have a lot to do with medicine. This is money. This is a portfolio of dollars. I'm trying to grow as high as I can possibly get it. And I know each doctor thinks that their specialty is the best one. And to each of you individually, I will say, yes, it is. Okay. But the truth is, we work in a landscape where we don't have control over a lot of the things. CMS has valued each of your areas of work differently. So that's where we have to work. Okay. We can carve certain things out. Trauma, right? We do level 1 trauma here. Okay. We can really sort of push the envelope on that. There are certain other things. Transplant is another big one too. Everything else, it's a little bit more difficult to be able to go in and say, we're the only ones here that do this. Certainly some specific services within the disciplines we do. I will also say that I think we do it the best. Okay. But at the same time, we also do it more expensively than other places too. And the payers see that as well. We train physicians. There's a cost to them. And that's reflected in the amount of the cost that we need to recoup from the payers as well. And they'll say, well, if I can get this from Dr. X at Swedish, who's not training someone at less, I'll just go there. So that's the market that we're fighting against. If we ever need to get into the specifics of why something should be covered or why an authorization should be different, we're working with the doctors all the time on that. In the negotiations, I'm not sure exactly. And this is, again, complete. What are your thoughts on the conversion factor is really, right? So I'm not sure exactly how that's going to factor into the negotiation. That doesn't mean I don't want to hear what doctors have to say. Not that we think that doctors' opinions aren't worth it. But then that negotiation itself, unless you're a trained contract negotiator who understands all CMS and other reimbursements work, you would just be an observer. Does that make sense? No. Correct, right. So at that point in time, so $3.3 billion, right? If this was a 401k, I'd be trying to build this as much as I can. It's kind of the same. We got to keep the doors open. And so this is not to say that anything the doctors have to say isn't valuable, but it's not medicine. It's something else.
Doug, I just want to speak to your point on the efficiency adjustment. We have run the numbers system-wide in terms of that, and we're expecting about a 1% decrease in work RVUs year over year. So for the 2026 values, and surgery is hit a bit harder. So we're going to be going through that on Friday at Finance and Audit, but it's disappointing, at least that, but also reimbursement actually will be taking a bigger hit because of the practice expense transition as well. So there's a lot of factors. So we're kind of trying to run all those numbers and think through. Again, I would highlight that the most significant thing, impactful thing that all of our practitioners can do is ensuring that they're appropriately documenting all of the care that's given in order for us to maximize those opportunities. And at UWP, FPPS, we're always working to maximize those. And in 2026, Hunter Wessels, a UWP board president, and I are working very hard to figure out ways in which we identify pockets of opportunity, recognizing that there's a lot of forces at work. And so we are committed to all of you.